Okay. Any questions on week 2 that ended in the beginning of week 3? Okay, I did add for this week 3, there's an assignment, a registry review assignment. Basically, all those questions on there that are from gastrointestinal are fair game for the boards. A lot of those topics and those type of questions are seen in registry reviews. So you want to make sure when you do that assignment this week that you hold on to it to help you prep for the abdomen section of the boards, which is heavy on the fluoroscopy. Okay. All right. We'll get started because we got quite a bit of PowerPoint since it is 2 sections here. Okay. All right. So we've got respiratory and gastrointestinal for this week. I added this PowerPoint for your review. I know you've covered this already, but you want to make sure that you do understand the blood flow of the heart. That will help you in answering any questions or talking about line placements of where things are located and how the blood is flowing. First thing they mentioned was the for chest was 2 placements. Okay. You have your endotracheal tube placement. If you guys are in clinical now, I'm sure you've done plenty of chest x-rays for this. You want to make sure this is your breathing tube placement, and you want to make sure you know where that tip is supposed to be, which is 5 to 7 centimeters above the carina. You can see the carina bifurcate here. Okay, so that tip's in place. If you're at clinical and you're taking this x-ray and you see it's clearly way past that, or even off to the right or left, or not even shown, then you want to alert them to take a look at it sooner rather than later. Okay. Central venous catheter, that's going to be inserted into a vein, usually neck or groin area. And that is going to enter into the superior vena cava. And they'll use central venous catheters to deliver fluids and medications. So I'm sure you've been called to do an x-ray for that as well. Your swan gans, that's inserted usually like femoral jugular area. And the swan gans is going to connect to the right side of the heart into that pulmonary artery. So you want to make sure you have the whole catheter on there. They use the swan gans to measure blood pressure, cardiac output, and oxygen levels for the heart and lungs. All right, first pathology in the respiratory system is that we're going to cover. Remember what I said, there is tons of pathology in these chapters. I'm choosing to focus on the more common ones that most technologists would know. Cystic fibrosis, that's characterized by the secretion of excessively viscous mucus from the exocrine glands. So this is an additive disease. You see here, oh, geez, I'm sorry, hold on. You see here all the mucus inside those lungs there from this. They have a lot of very obviously hard time breathing. They can't usually walk long distance because of the breathing from all that mucus buildup. Croup is a viral infection for young children that produces inflammatory obstructive swelling in the trachea there. So you can see the narrowing of the trachea when you do a soft tissue AP neck, lateral neck. You'll hear the child usually has a barking cough. And that's what they're looking for in that, to see if the trachea is narrowed and the swelling. Pneumonia, it's your inflammation of the lung. It can be caused by a variety of organisms, but usually bacteria or virus. So once again, that's an additive disease. You see the whiteness here from the inflammation. So if the patient had right lower lobe pneumonia and was non-ambulatory, what view book-wise would we be doing to see the air fluid levels? You can throw it in the chat. So it's right lobe pneumonia. Give everybody a minute to answer that in the chat. And which decubitus, because I'm specific, I said right lower lobe pneumonia. So how do we know? How do we decide if we're going to do left lateral or right lateral? Right? The question with chest, if they're asking you which decubitus with chest, the question is, well, where's the pathology? The pathology was in the right side. Okay. What's the rule for chest decubitus?
Fluid down, air up.
Exactly. Yep. So with chest decubitus, fluid side down, air side up. Pneumonia is fluid, right? That's that white. So it's fluid. So it's fluid side down. So if the patient has right pneumonia, then it's right side down. Okay. Remember, those are typical board questions. Non-ambulatory patients, they're going to want to know how you're going to see the air fluid levels. You're not going to say you're going to sit them up like you do in clinical. The textbook answer is decubitus with obviously a horizontal beam, but then we have to know which decubitus. So for chest, we're asking which side the pathology is on and what type of pathology it is. What is a type of pathology that's an air pathology?
Pneumothorax.
Yeah. So a pneumothorax, if it is left pneumothorax, go ahead and type in the chat, please, everyone. If it is a left pneumothorax, which decubitus are we doing? Go ahead and put yourself in the chat there with the answer. So it is a left pneumothorax. Yep, so we want the left side up, which means we are now in our right lateral decubitus. Very different from abdomen, right? If the patient's non-ambulatory, please type in the chat which decubitus you're going to do for an abdomen to still see air fluid levels. So we've got a non-ambulatory abdomen patient. Everyone should be typing in the chat which decubitus they're going to do. Okay, now abdomen is different. Abdomen, I don't really care what the pathology is. I am always going to do, if I'm looking for air fluid levels on my abdomen, I'm going to do a left lateral decubitus. Why did I choose a left lateral decubitus? Why can't I do a right lateral decubitus? What are we looking for in an upright abdomen? Yeah, we're looking to see if there's any free air, right? We want to know if there's any free air under the diaphragm, correct? What's the name of the pathology, the term for free air under the diaphragm? Free air under the diaphragm, right? That's not supposed to be there. If it is there, likely it's some type of maybe surgery caused it, right? Comment after surgery. Yes, there you go. Pneumoperitoneum. That's a word you'll need to know for the boards. That's the whole reason we're doing upright abdomens and that's why we have to include the diaphragm. That's why our central ray is above the crest, right? We're not at the crest like we are for the supine. We're above the crest because we have to have the diaphragm on there. We're looking for free air under the diaphragm. So why do I want to put the left side down then? What am I trying to get out of the way by putting the left side down when I'm doing the abdomen? Why do I want to do a left lateral decubitus and not a right decubitus? What would be on the left side in the abdomen cavity that I would want to get out of the way because there's already air there and I don't want to confuse myself? I'm trying to push the what down that has air in it naturally. What's on the left side that would have air in it that I'm trying to push down? Exactly, the stomach. I got to get the stomach out of the way. So I'm going to put his left side down, right? And then his right side's going to be up so I could see if there's free air there under the liver. All right, so abdomen decubitus is always going to be left side down because you got to get that stomach air out of the way. And usually for the boards, they're asking you what you're doing and why you're doing it. It's always because you want the stomach down so you can see free air. And that would be the pathology of pneumoperitoneum. Okay. Very good. Anthrax. Anthrax is caused by Bacillus anthracis. It can survive for decades. It's easily transmitted and highly fatal. I think we all know that from that whole period of anthrax there. Most of the anthrax that was spread was through inhalation into the lungs and is very fatal. Tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. It's a bacteria that can live outside the body for a long time. It spreads by droplets in the air. That's why they have all separate droplet precautions for tuberculosis patients. The biggest question for the boards is always, what do they usually order a special view for? If they're looking for tuberculosis, that special view is the apicolordotic view, because we're looking at what part of the lungs when we're looking for tuberculosis. That's typically found where? What part of the lungs? Yes, in the apices. So how are we going to see the apices? We've got to get those clavicles out of the way. You've got to throw them all the way up. So if your patient cannot, lean back onto the image receptor, then you're going to have to do your apicolordotic view, which for the boards, you will have to know why you're doing an apicolordotic view to see the apices. And usually it's a pathology like tuberculosis, or if they see a little nodule there, you will have to know what the degree and the angle is for that. And that's your 15 to 20 cephalad. Be careful if they're referring to an AP chest or a PA chest. What if the question on the test says the patient is in a PA and you want to do apicolordotic? Would you have to change anything? Yeah. Remember, for any body part, you're going to memorize it a certain way. You need to know what position your patient's in for the way you're memorizing it. So if you're ever memorizing apicolordotic as 15 to 20 cephalad, and then on the test, they flip the patient and they say the patient's in a PA, you're going to go the opposite. You're going to go caudad. Okay. So very important that you pay attention to your questions. Anytime you're about to answer a question that has to do with an angle, reread the question to see if the patient was in an AP or PA. Very big with chest on that, and also coccyx. They like to do that with coccyx. Okay. People memorize coccyx angles in an AP position, a supine position, but a lot of times on the test, they'll put the patient in a prone. So be careful of that. RSV. RSV attacks the lower respiratory tract, causing necrosis of the bronchi and bronchioles. A patient with RSV is going to have hyperinflation, this wide chest look, and interstitial markings all around. Pulmonary embolism, a PE. These usually arise from deep vein thrombosis in the lower extremity. So that blood clot that they have in the lower extremity is going to travel to the arteries in the lung. It could be very fatal. You can see it really nice on a PE protocol for CT when they administer the contrast. It's timed to hit and to highlight that pulmonary artery there, so you can see where the clot is. COPD, chronic obstructive pulmonary disease, several different conditions where there's obstruction in the airways leading to an ineffective exchange of respiratory gases. So they're obviously going to have a hard time breathing. They can get emphysema, asthma, chronic bronchitis. You'll usually be able to hear them as you're, getting the history on the patient, realizing that they are going to have a lot of inflammation there. Emphysema. This is a chronic lung disease damaging the alveoli, so there's going to be hyperinflation. A lot of times, patients will have the hyperinflation lengthwise, so you have to be careful because you may clip the bases there if they have hyperinflation lengthwise. Okay. Asthma. Asthma is the airway becomes inflamed and swells, producing extra mucus. So they'll have difficulty breathing and they'll start getting bronchial narrowing. Pulmonary metastasis. This is usually caused from carcinomas of the breast or esophagus and stomach, and then they spread to the lungs via either direct extension or due to anatomic, via a direct extension due to the anatomic proximity of how close it is. So you can see all the nodules on that chest there. Atelectasis is defined as a condition in where there's diminished air within the lungs, so reduced lung volume. So it's caused by bronchial obstruction, either from a foreign body or a mucus plug. But you're going to fill up here. You see these white areas here of atelectasis. Subcutaneous emphysema. This is free air in the tissues of the chest wall. It's usually characterized by a crackling sound on palpation. This one always fascinated me. It's crazy looking. Pneumothorax, there's our air pathology, our destructive disease. It's the presence of air resulting in that partial or complete collapse of the lung. So this is going to be one of your destructive diseases in which you would have to decrease your technique for. And like we said, if they're a non-ambulatory patient and we have to do a decubitus, and it's going to be air side up. Here's a couple of pathologies that are commonly asked on the board as far as how to adjust your technique. So make sure you're aware of that. Which ones are air, which ones are fluid. Fluid, you're going to increase your techniques, and the air, you will decrease your techniques. So make sure you at least know that with your common pathology. Okay, gastrointestinal. Esophagitis. This is an acute form, is most commonly the result of reflux of stomach contents into the distal esophagus. So they'll call that GERD, your gastroesophageal reflux disease. And chronic esophagitis may actually lead to strictures or Barrett's esophagus. So you can see a little esophagitis there, and this one also has an ulcer in the esophagus. On the registry review assignment, there are some questions, a handful of questions there about esophagograms that are important for the boards. So as a bit with that this week. Esophageal diverticula, outpouchings of the esophageal wall. You can see that here with the arrow pointing to it, the little outpouching. Esophageal varices, dilated veins in the esophagus. That's pretty obvious. Portal hypertension caused from cirrhosis, and they may hemorrhage. It's pretty nasty looking. A hiatal hernia. That's a protrusion of a portion of the stomach into the thoracic cavity through that esophageal hiatus in the diaphragm. Commonly causes GERD. See that nicely when you administer, when the patient is drinking their contrast. Gastritis, that's inflammation of the stomach mucosa, caused from irritants like alcohol, infection, corrosive agents. Pyloric stenosis, that causes obstruction, preventing food from entering into the duodenum there. So you can see this narrow opening between the stomach and the duodenum from the thickened muscle there. Crohn's disease. This is a chronic inflammatory disorder, and it usually just involves that terminal area of the ileum. That is sometimes on the boards where Crohn's is located, and that would be your terminal area of the ileum. Could affect any part, but that's the most common area. Small bowel obstruction, you see fluid levels on this abdomen here. Small bowel obstruction is often caused by adhesions from surgery. And then the second most common cause would be from hernias. Intussusception, that's the telescoping of one part of the intestinal tract into another because of peristalsis. That's going to force that proximal segment of the bowel to move distally within the outer portion. That is a major cause of obstruction in children. You'll see that. You see them all distended, then as soon as you take the abdomen, you'll see all that bowel pattern. Diverticulosis, it's outpouchings that are acquired herniations in the mucosa there. Diverticulitis is necrosing inflammation in the diverticula. And some complications from that, they could get perforation or abscesses. Cancer of the colon. Cancer of the colon is a third leading cause of cancer death with a peak age from 50 to 70. A lot more people are getting it a lot younger now. It's been all over the news recently. I have a friend who was just diagnosed with it, and she was only 45. And they're saying not to get a colonoscopy till you're 50, but I think they may end up changing that age because of how many young people are getting colon cancer. Predisposing factors would be a family history of polyps or long-term ulcerative colitis. Volvulus of the colon, that's when the bowel twists on itself, which could then cause an obstruction. You usually see that around the cecum sigmoid area. Hemorrhoids, varicose veins of the distal rectum. You can see the enema tip there. You'll get pain, itching, and bleeding. And it's usually caused when there's too much pressure, like constipation, pregnancy. Acute cholecystitis, that's an acute inflammation of the gallbladder, usually caused by a cystic duct obstruction from a gallstone. So that's something they would need a ERCP for to evaluate. Endoscopic retrograde cholangitis pancreatography. Hepatitis, the most prevalent inflammatory disease of the liver. Common causes, viral infection or reaction to drugs and toxins. You've got your 4 different hepatitis viruses. And then, of course, healthcare workers are at risk from contaminated blood and blood products. That's why there is a vaccine usually available for employment at the hospitals. Okay, so a little, quiz is going to be a little bit longer. You can look on the weekly module to see how many points. I can't remember off the top of my head, but a little more than last week because we do have more PowerPoints, more pathology that we're covering this week. So make sure you take these, review this lecture again, the recording again, so you can make your notes, your study guide for yourself. Flashcards always help. Taking the terms that are on here, the pathology terms that are on here, making yourself flashcards so that you could pick it out in a multiple choice question. Okay, so don't ignore these PowerPoints, create them into flashcards or, terminology test for yourself so that you're ready for the quiz. So take the quiz by Sunday midnight. Okay. So now I see, do we get the diagrams to identify the pathology in the quiz? What do you mean diagrams? Which diagrams are you talking about? Uh, yeah, you won't have X-ray images on a quiz asking you. That's more of a radiologist type of education. They wouldn't put a bunch of different radiographs and ask you what pathology it is. That's not your responsibility. Okay, so no, there won't be chest X-rays on there asking you what pathology. Yep, we can look at the heart here. Let me just minimize this chart a little bit. Okay, I like this one, this little illustration. Everything on the right here in blue is blood going to the lungs. Okay. So they're going to start at the superior vena cava into the right atrium, through that tricuspid valve there, down into the right ventricle, up through the pulmonary valve into the pulmonary artery. So now we're going into the lungs to be oxygenated. And then we'll go into the pulmonary vein to the left atrium, through the mitral valve to get to the left ventricle, and through the aortic valve to get to the aorta. I don't usually ask you the full blood flow, but I don't know, maybe they may pick one of those, to question about. Blood flow is very important if you're going to work in any modality with IV contrast. Okay. Anytime, if you're in CT or MR or interventional, where you're administering contrast, there's a lot of studies that are going to require you, that's a specific, that you want the contrast in a specific area. So knowing your blood flow is important with that, to help you, so you know when is the right time to take the image. Okay. The pathology on the quiz will be respiratory and gastrointestinal pathology that was covered in this lecture. I will not be giving you images, just multiple choice questions, with definitions and matching up and choosing the right medical terminology. Okay. Just want to keep it, as simple as possible, because the boards are not heavy in pathology. The boards have 1,000 other things to ask you about. That is why I did give you that registry review for an assignment, because now's a good time, since we're working on in the abdomen area there with gastrointestinal. It's a good time for you to review all the things that are going to be asked about you. If you have completed the assignment and you are really stuck, on some of the questions, if you want to shoot me an email, if you're stuck and you just can't find it anywhere, you can always shoot me an email and I can guide you through that. Okay. But that sheet, that assignment is going to be important for you to put in your little folder to prepare you for the registry, because that area tends to be a weak area for students, the abdomen area with fluoro. Any other questions? And then make sure also for the boards, I put that grid in there with the technical adjustments. You have to at least know that pathology. You can give yourself a 50-50 shot if they throw other pathology in there that you don't know. Usually what it will be is it'll be like 4 pathologies in the multiple choice. And if you know 2 out of the 4, then you'll be able to get the question right. So if you can narrow it down, okay, pleural effusion, pneumonia, that's fluid, pneumothorax is air. They're asking me which one is going to would require a decrease in technique. As long as you got your air fluid pathologies down for common terms, you should be fine with that, okay? All right, if no other questions, then you can just type your name back in the chat to sign off. And like I said, if you get stuck on any of that registry review section, you can email it to me and I can go over it with you. Have a good night and good luck this week on your assignments and your quiz. Next week already is week 4, which is going to be midterm and urinary system.